what exactly do they need to be successful. And I think because this is so new and we want to do a good job, we wanted to have that kind of flexibility. So certainly it's really more so about being able to be responsive to support local success. In my mind and my vision of having the opportunity to have these resources and really having it be a partnership with our local implementers and all of our stakeholders and advocates to say, how do we best use these funds to make this significant system change? And so I'm hopeful that will be what we're able to accomplish with the opportunity to have those funds.
Yeah, I would add, Senator Pan, that certainly the big approach with consultants, I think, is to make that local connection. We all see this as local work. It will be guided by principles and ideas that emanate from across the state, but really will have to be implemented like so many things locally. And as I've been listening to various counties at different stages of development of these programs, having that expertise that matches where they are and being able to leverage some local knowledge to build these programs is going to be key, and having resources to be able to tap into that knowledge, even if only for a temporary period of time, is going to help us. And as you noted, it does not reduce the need for us at the state level to create this expertise, this lasting understanding of how we're evolving this work in California, building on best practices across the nation, taking that research that we know other places, including parts of our own localities here in California, are creating. So we see it as both. We don't see that the contracting out function or the contracting function here is really to replace that expertise at the state level. We're really enthusiastic and excited to develop that knowledge, that expertise, and frankly, that leadership. We believe that this work is not only going to catapult California forward, but will really enthuse national work, and having that expertise within our own office at HHS will be key and something that evolves over time. So it's really focused, as Stephanie said, on that local piece, that local capacity building first, and then also simultaneously building up our own expertise within the new office.
Okay, thank you.
Thank you very much. Okay, I think then we'll move on to your next big one, Dr. Galley, Children and Health Youth Behavioral Health Initiative.
Great, and it is, with OICR and this program, it's a privilege to be able to present them together because they are in fact linked. And this large behavioral health initiative focused on young people 0 to 25, I think, really represents a down payment on the future of California. And as it's been said, how we spend our resources, our time and our energy is a true reflection of our values. For the governor and many legislative leaders, these investments, both of time and funding in young Californians, are core pillars to supporting a state that thrives now and into the future. Since the beginning of the pandemic, public health educators, so many other child-focused professionals across the state, across the nation, have been concerned about the pandemic's impact on young people. Those of us with young children, I have 4, have witnessed firsthand the challenges young people have faced over the last 15 months from a social and emotional point of view. And although the toll has been tremendous, we cannot behave as though this is all new or started because of the pandemic. Of course, the pandemic has exacerbated and deepened this smoldering crisis, and many of us have been tracking this for a long time. But the slow and steady increases in behavioral health conditions by young people have been building for many years. We've seen classrooms disrupted by children who are screaming out for help through both their actions and their words, parents with nowhere to turn, teachers and other supports, similar, long waits for services, if they exist at all, pediatric emergency departments that are filling up with young people night after night, families and communities in crisis because children are stressed, anxious, depressed, and in some cases experiencing psychosis. Community tools to address the early manifestations of these important and now expected challenges just do not exist in a sufficient quantity. And I often say pediatrics is the ultimate form in adult preventative medicine, and it's nowhere more true than with behavioral health. With the link to emotional well-being and stability, really linked to success in adulthood, and the corollary, as our Surgeon General has helped us see, that increased toxic stress and exposure to adverse childhood experiences, we see the connection to poor health outcomes in late teens, early adulthood, and throughout adulthood. We should not require much more evidence to increase our resolve to act now. The link between homelessness, incarceration, and undertreated children's behavioral health and emotional health is well known. If we want to change the arc of the lives of the next generation, few investments can be more impactful than supporting young people through the ups and downs of growing up and being on our toes, ready to support them when the manifesting behaviors emerge. We know that as we wait, as we witness those behaviors and have few responses, that the challenges ahead become harder and harder for young people. I'll just take a moment to tell you a story, true story, that I experienced myself in right outside my Southern California home, quiet community, tree-lined, and a neighbor called about a young man, turned out to be 54, we'll call him Mr. Mims, who was in the alley in his filthy blanket, hands down to his knees, talking to himself, clearly altered, and being challenged. I had a chance to sit with him in the alley after calling somebody I knew in the Los Angeles area to come and help. And I had a chance to hear his story, one that reminded me then and reminds me today, like so many other stories that I know and we all know, of how we missed an opportunity. Mr. Mims, born in South Los Angeles with a number of siblings in a pretty hard and tough part of South LA, became gang involved and early on, justice involved. By the age of 12 or 13, I can't remember which, was on his way to the California Youth Authority, where he spent the rest of his teen years. It broke him there. He clearly described a story of difficulty and challenge, and he left with a bit of bus money and a mental health diagnosis, he said, without meds, without a place to follow up. He came back to a family that wasn't really prepared for him. And 4.5 decades later, a number of stints in county jail, unclear if he was back to our prison system, in and out of facilities. He was there in this alley on my corner, and he said to me, "This might be the time that I finally get help." And I was proud and pleased to be able to reach out and serve him in a small way. But it reminds me that programs like the one we're proposing here in this May Revise give us a chance to identify the Mr. Mims as younger children. We know that half of behavioral health conditions emerge and can be diagnosed by the age of 14, full 3/4 before the age of 25. We know that we have underscaled behavioral health programs across our state. As a primary care pediatrician, somebody who worked with youth in foster care, as I said, in the juvenile detention facilities in LA, not just in Los Angeles, but San Francisco County. It's been long waits figuring out where families can get early help, early support for conditions that we know are just the beginning of more serious consequences down the road. This opportunity today, I think, to make these meaningful, strong investments in this in behavioral health, give us an opportunity like none other. Some people have said and asked what sorts of things have motivated such a big proposal in the May Revise by Health and Human Services. It's long been a focus of ours to really be committed to young people, committed to their health, the need for social services and those family supports. But in a unique time where we've learned so much about the pandemic, through the pandemic, about how to deliver effective health services when we can't depend on everything happening in person, when remote strategies needed to be not just tried, but in many ways perfected, where we knew that we had to reach people in parts of our communities where we weren't able to get services previously. We just had to succeed, and we did a lot of that with the transition to telehealth, telebehavioral health, saw the manifestations of those tools as benefits, but they can't be the only strategy. And our proposal depends on those somewhat, but not entirely. Similarly, when we have resources like we do now to make one-time infrastructure investments so that years down the road, we no longer have the reason, the excuse to say we would refer a young person to services if only it were available, if only it existed, to really be focused on the lessons around equity, language concordance, building up a workforce that not only speaks our language of California, but looks like the Californians who need the services. We have this tremendous opportunity here and now to build up these resources. And so the proposal which we have put together really with the governor at its front and back to focus on kids broadly, connected to so many other things that you see in the January proposed budget and now the May revise, whether it's the connections to the CalAIM investments, the school investments that have been proposed, particularly community schools, our many infrastructure investments being proposed around the behavioral health continuum, those other services, just like the Office of Youth and Community Restoration, the other school mental health investments, whether it's through planned MHSA funding or the proposal on school-based mental health through our Medicaid managed care plans that was proposed in January. Today's proposal that we're presenting, I think, is this broad foundation to build upon that recognizes the incredible investments that already exist. So to summarize, there are really 8 components to our proposal. The first, it starts with building a behavioral health services platform that is focused on being for all young people and young adults 0 to 25 in California. We've talked about being payer agnostic, meaning it isn't just for kids and young people on Medicaid, it's for all kids in California, focused on early interventions, focused on being anywhere, anytime, any language, meeting young people and their families where they are. And this virtual platform is planned to really be available to all young people, linked to our schools, working in partnership with educators, built on a bit of the community school model, but hopefully available to schools everywhere across the state. That virtual platform will focus on assessments, linkages to other tools, connection to behavioral health, telebehavioral health, whether that's individual sessions or groups, bringing young people together from across California, supporting them in their communities through the virtual platform, but knowing that it is just the front door to this incredible set of resources that needs to be supported as they already exist, but really built up. We know also that unlike on the mental health side, where we have a fairly fragmented system with gaping holes for young people achieving and getting the care and services they need, on the substance use disorder side, frankly, we have a nearly non-existent set of services for young people. Yes, some stellar programs that I've had the privilege of sending patients to over the years, but they are few and far between. The opportunity to build up the substance use disorder services through not just virtual services, but real brick and mortar services is a key feature of this plan. The second piece, just sort of building on this a little bit more, is building up the capacity and infrastructure of our health plans, county mental health plans, our CBOs in our schools, as we've discussed. The third component is developing and scaling up behavioral health evidence-based programming. There are many in California that are already in place, but there are lessons to be learned from across the nation and the globe that we can bring to California in this model that allows young people to have their care essentially stepped up. If their needs can be met and supported in a virtual way, it's terrific, fantastic. But as soon as they would need more, we could transition to a meaningful set of other programs. And that leads to the deep commitment to building up our infrastructure in children's and young people's behavioral health. This isn't just outpatient resources where clinicians can see young people for visits and treatment, but also urgent care centers, which I think some counties have already, many don't, which can serve as a place to de-escalate crises, support people in a less acute care setting, very effective in the adult behavioral health world in California, something we could scale up here more for young people. And then, of course, we've highlighted before the dearth of inpatient and other emergency acute care services for young people, building up those beds so that we had capacity for the most significantly affected young people to get the care that they need in a convenient way. Can't tell you how many nights I spent on the phone working with county behavioral health in Los Angeles, identifying placements for young people, regardless of where they were in Los Angeles. We often had to send young people out of county to get the care that they need. I hope that once we implement this proposal, that no family, no community in California has to send their young person too far away to get the care they need. We can do it in a convenient and better way. Of course, we want to enhance the Medi-Cal benefits through this proposal. We see a number of important pieces, building up dyadic services, evidence-based services that lean on usual source of care to coordinate services across families, across young people, specific treatments and therapies that are evidence-based, being able to scale those for kids in the Medi-Cal system, their families, and supporting it so that it's broadly used, not just in Medicaid, but also across the care continuum for children everywhere in California. Connected to our community health worker benefit that's being proposed also in the January budget, ensuring that our tremendous program for ACEs and screening that our Surgeon General has built up, and I know her team's here with us today to be able to answer any questions, but to ensure that that is something that's accessed across Medicaid into the future. We also look at this as a tremendous opportunity to build up our workforce. I can't tell you how many exciting new initiatives I've had a chance to be a part of, not just on the health side, but the social services side, where we're able to build the facilities, we're able to bring the IT systems to bear. Funding is no longer the main challenge, yet we continue to have a workforce challenge. It's our people that we need. We need to build them up with an eye to what California needs, what our diverse communities need, so that those who are working in children and young people's behavioral health are able to speak to our clients, their families, and really do it in a way that is culturally aligned. So a large set of investments, both to focus on building up the workforce in the community, at our schools, and in traditional behavioral health settings. There's an important piece, and we know that both, Dr. Pan, this will resonate with you, of course, as a primary care pediatrician, I as well, those family practitioners, internal medicine physicians, all of us who have the privilege of taking care of young people in that primary care setting often need some support with behavioral health services and connections, what to do, building up the capacity to have a statewide e-referral, e-consult system available to all primary clinical professionals who are encountering young people in the community, to be able to link not just to services, but to immediate advice on how to support those young people and their guardians and communities to early on get through some unique challenges. We also recognize the key role on communicating, educating, engaging, and outreaching to communities. So a significant campaign planned crossing over between our Office of the Surgeon General and Department of Public Health, really building on lessons that we learned during COVID that balance the need to communicate clearly and simply, but in a sophisticated way to reach all parts, every nook and cranny of California in all languages, so that no one is left behind. The last piece of our proposal is focused on coordination, and this is specifically the part of the work that Health and Human Services will lead, the coordination of the building blocks across the many different departments. I think we have 6 to 7 departments or offices within Health and Human Services alone that will be working on this proposal, each with a distinct piece of the puzzle. Each piece needs to be coordinated from the front end, and HHS leadership and positions within our agency will help do that coordination. It will allow us to bring on subject matter expertise to build around Stephanie and our entire team that is very enthusiastic to continue to do this work, to learn the lessons from our counties, our communities, and be able to assimilate that in ultimately the design of our programs, the procurement of any of the tools that we need, either statewide or by region. And then, of course, the very necessary, important evaluation component that we want to build in at the front end. We know that this is a very significant investment, one that I think many Californians believe will pay dividends to young people today, but really also to our future. And to be able to evaluate as one of the boldest steps that I've seen across our nation for building up children's behavioral health services, to be able to make the case for what we learned, why we did it, and how it's changed the arc of young people, and frankly, the composition of our communities. When I look at the rates of incarceration, when I look at homelessness and I see the direct tie, as we spoke to before, I see the shadow and image of Mr. Mims and thousands like him in our state, I think we can be proud and evaluate the efforts here to show the impact that we have. So with that, Madam Chair, I'll turn it back to you. We are happy to take questions. I know Stephanie and the Office of the Surgeon General are here to answer any questions specifically on this proposal. And we really look forward to doing this in partnership with the legislature, but also all Californians who've been interested in this issue for so long. I really commend the existing leadership and look forward to being partners lockstep all along the way.
Thank you very much. And before I turn to Department of Finance and LAO, on behalf of me, but I think all of us here, Dr. Galley, we just want to thank you for your leadership during this entire pandemic. You have really been on the front lines and providing a calm voice of reassurance, I think, to a lot of people. And further, I know with myself and I know Dr. Pan, we've also met all of those Mr. Mims and have bemoaned the fact that we couldn't have done more before, and see the tragedy on our streets today of things that we didn't take care of earlier. So this is a big, and so just to say, we thank you for the heart that you bring to us, your experiences that are still clearly very fresh, and you're able then to be a very astute problem solver. So we thank you and your entire team. We would also say this is a huge endeavor that you're proposing, and the problem is huge, and so you've got a certainly huge issue. I think we'll be very interested in that technology, as we've all been struggling through issues around technology right now. And of course, all of this will take some time, and we know I've expressed, Dr. Pan has certainly expressed, that we have a real urgency now in behavioral health for the folks that we've talked about in the streets a lot of times, but in our children right now, we know that is incredibly urgent. So while we're looking at a lot of these long-term things, we can never take our eye off the emergency in front of us now. Department of Finance, anything from you on this?
Elena Ramos, nothing more to add. Thank you.
Thank you very much. LAO, anything to add on here?
Thank you, Senator Eggman. Corey Hashida with the LAO. We've conducted our initial review of this initiative and do have some considerations to raise. As you know, there are various components to this initiative cutting across multiple departments, including HHS agency and OSHPD as being discussed today. So my comments today will be overarching in nature, focused on the initiative as a whole. First, we would just note that, across the various components of the initiative, there are areas where the legislature is going to need further detail to properly assess the merits of each proposal. The administration has indicated that there's going to be trailer bill associated with this initiative, which may answer some outstanding questions, but that trailer bill is not available for legislative review at this time. In addition, based on the information that is available about the initiative, we find that in general, while there are relatively smaller portions of the initiative that relate to the ongoing provision of services, such as a new benefit in Medi-Cal for dyadic care, spending under the initiative would largely be focused on one-time investments for capacity and infrastructure. For example, the creation of the virtual platform, which Secretary Galley just mentioned. These one-time investments to overhaul behavioral health delivery have merit, but we would just note that the potential benefits to children and youth as a result of these investments may not ultimately be realized until some years into the future. And so to the extent that the legislature wishes to prioritize getting services out to children and youth as soon as possible, given urgent need, we would just note this trade-off exists between prioritizing infrastructure and capacity and over sort of services now. Next, although there are relatively smaller components of the initiative that do provide a fiscal estimate of ongoing service costs, in general, the administration does not score ongoing costs that may arise from the greater capacity for services that will hopefully result from the major one-time investments of this initiative. There's also another proposal in the Department of Managed Healthcare to implement a statutory change to require commercial and Medi-Cal plans to cover services in school. And similarly, there's sort of no indication of a fiscal attached to sort of that statutory change. We find it possible that, these investments would result in additional ongoing costs that would sort of need to be accounted for. Next, we would note that a sizable portion of the initiative is proposed to be provided as grant funding to a variety of entities. These could include, community-based organizations, schools, universities, counties, health plans. Given the many different entities that would be available, that would sort of be eligible to apply for grant funds, we find that key details related to how these grant programs would be designed, especially in terms of what required benchmarks or metrics applicants would need to meet in order to obtain funds, would need to sort of be clearly articulated, given that these entities may have different capacity for meeting performance benchmarks in order to receive funding under the grant programs. We would also just flag that, sizable portions of the initiative are intended to provide services and supports to all children and youth, regardless of payer, sort of beyond the scope of public programs for which the state traditionally would have more responsibility over overseeing. This approach may have merit, but the legislature may wish to consider to what extent it agrees with the approach, or if it would wish to target funding towards more towards public programs such as Medi-Cal, which the state has traditionally been more involved with. Lastly, given the enormity of this initiative, we find that fleshing out the evaluation component of the initiative is going to be vital to ensure that demonstrated measurable outcomes are achieved as a result of these proposals. The administration mentions in its initiative documents that it intends to commission an evaluator to sort of evaluate all components of the initiative. This is really our extent of what evaluation components will be built into this initiative. And so based on this, the legislature may wish to sort of ask the administration to draw out specifically how the initiative would be evaluated in more detail. It's a sizable lift to sort of have one evaluator look over the every aspect of the initiative. Those are all of our office's overarching comments at this time. Again, this is based on our initial review, and there may be answers to some of the points that we raise in the forthcoming trailer bill when it becomes available. We're sort of happy to provide further assistance as needed. I believe my colleague Sonia Pettick is in the hearing as well, and we were hoping to sort of pass along our comments to her so that she could comment on sort of the HHS agency specific parts of this proposal, if that's okay.
Ms. Pettick?
Thank you, Senator Eggman and my colleague, Mr. Hashida. We just have a couple comments specific to the proposals that are within the Health and Human Services Agency and the Office of the Surgeon General. We have just a few questions that we'll be reaching out to the administration about, and like my colleague said, we're still awaiting additional details from the administration, which will help us conduct our assessment. But just to mention, in the Office of the Surgeon General, there is $25.1 million proposed, most of it in the first year, and the bulk of it for what's called an ACEs Aware campaign, or Adverse Childhood Experiences Aware campaign. We would just note that in the governor's budget in 2020, there was a very similar proposal, but only $8 million was proposed for this activity. And so we're hoping to get more information from the administration about how this campaign will work, and about just the discrepancy in the amounts requested last year and now this year. In addition, there's $1 million for the Office of the Surgeon General to develop a training curriculum for educators. And our two primary questions here are why other sectors of government workers are not targeted for the training. So in the proposal last year, the Office of Surgeon General was considering training for sectors such as law enforcement and social services and the like. So we were wondering why education alone was targeted here this year. And we also are wondering about some of the implementation details on that training. So for example, is the Office of Surgeon General intending to, or do they hope that all educators in the state will eventually be trained, or sort of what's the breadth and reach of this training? And then finally, when it comes to the role of the Health and Human Services Agency overall, this is a request for $50 million over 5 years. Our primary question here is just how much funding will go to the individual components, and how were those estimates derived? We just are still missing some of those key details. Thank you very much.
Thank you very much. And so for all of these things, I mean, clearly we're going to have a lot more questions when we get a lot more details, but for the purpose of today, and since she's here with us, would the Surgeon General like to, and I don't know that you need to respond to discrepancies because I don't know how involved you were before, but do you want to be able to respond to some of the issues raised by the LAO? And I will just say, if we think about doing a big public awareness campaign around ACEs, which is great, I would guess it would say, if you have questions, call or contact this number, which would then say that we would have this new IT infrastructure all set up yet. And so I don't, are those two inextricably linked, or could one start without the other? Surgeon General?
My name is Matt Schuler. I'm the Chief of Staff for the Office of the Surgeon General. So with respect to the cost of the public awareness campaign in the current budget relative to the prior ask, it's really about capacity, being able to extend the reach of the campaign, as Secretary Galley mentioned, being mindful of the inclusion of as many languages as we can accomplish, and really just extending that reach because of the impacts of the pandemic. These issues were incredibly important before, they're even more so now. So we feel that the amount allows us to do that more comprehensive reach that is needed. And with respect to the question about the connection to resources, it certainly does take time for public awareness to build. So we believe that we need to be getting the message out there in advance of some of these services being available, but we also do have some services available. Within the ACEs Aware initiative, we've been training healthcare providers for the last almost year and a half to do screening for ACEs and toxic stress and to be reimbursed for those screenings, and then provide mitigations within the primary care home. So it really kind of sets the stage for being able to be ready for the services as they are built through this initiative.
Okay, does Ms. Welch or Secretary Galley want to respond to the issue around evaluation and its kind of various components that we'd like to see a little bit more nailed down?
Yeah, agree that there's important components of the evaluation program and plan that can and will be shared. I think the point of the LAO is an important one, that it's a complex, braided project that will require certain components to be evaluated independently and as part of the whole. For example, the virtual platform at the scale of California, whether it's done statewide or in a couple of regions in California or splitting the state up in regions, that will require its own evaluation that will look very different from the components of evaluation on our workforce development projects. Those may certainly be evaluated around how quickly and high quality the trainings are, how quickly they're in place, the length of time those programs take, how successful we are to recruit a broad and diverse set of candidates to be part of the workforce. So each of these things is worthy of its own evaluation, and then we will look to evaluate the entirety of the project over time. The evaluation in many ways will be manifest, as you've said, down the road with the impact and the change of life options for young people, and we will be mindful of that. I think we have some tremendous colleagues in different parts of the state, both academic and other evaluation groups that can support and help the state. And then, of course, there will be department by department specific evaluation components here as well. So that is certainly being worked out now and will follow and be modeled around the specific components of which I laid out 7 key buckets that each part of that will require some evaluation. Stephanie, I'm not sure if you want to add to that.
Yeah, I think just to clarify, there's, as the Secretary said, there's a responsibility to look at process measures and to see if individual pieces are effective. But then there's this incredible opportunity to take the time to look at how they all work together. I think that's kind of what we see as the necessity of really coordinating the evaluation, to really look at also where do we go when the 5 years is up? Where do we sustain? Where do we create future investments? What did we learn? And really hope that the findings from a coordinated evaluation lead to more policy and system change.
Thank you very much. I think I'm sure Dr. Pan has some questions. And again, Dr. Galley and everybody, nobody disagrees about the problem. I think we'll just have some concerns about the solution that you've come up with. Dr. Pan?
Thank you so very much, Chair Eggman, and appreciate the presentation. I think we could probably spend all afternoon actually talking about this, but I know we have many other items. But I did have a few questions. And again, appreciate the proposal and the administration's plans to, as I said, build this, and basically, essentially, this investment in children's mental health. And I would just maybe first comment that, I understand the LAO talked about, do we approach all children or some? I would just, especially since it seems like a lot of this proposal is being school-centered, as someone who used to be a medical consultant for a school district, it's very hard for a public school district to go and actually only offer services to some of the students that attend their school and not to others. and sort of as we say, as we sort of have decided as a society that people should have universal access to, to public education, whether some families partake of that or not, is a difference, is their own decision. But if they do, that all students have the opportunity to be treated equally and have equal access to the various services in the school. So I guess I would argue in agreement with the administration that we should come up with a program that, especially the parts that are school-oriented, that they need to be universal and not subdivided according to whether insurance coverage or other types of metrics. I guess one of the things I would note in this proposal is that, again, realize it takes time, but for example, it seems like one of the core things is this behavioral health services virtual platform. And certainly I think this could be a very important investment, and it also takes time to develop. But I also make note that it begins in 24-25. So if you take a high school student who's in 9th grade who is having mental health issues because of COVID, they'd be graduated before that even came online. And graduated and perhaps not going to college because we haven't been able to help them. Now, I know we have other things that we might be able to do for them, but so I guess one questions I have, and I think this came up in our previous hearing, is that, well, I certainly appreciate many of the investments, and we have the workforce part as well, and it's going to take time to train people, et cetera. How do you see staging out different things so what about the kids right now who are suffering mental health issues because of COVID? How do you plan to basically stage things out so that they can get help even as we're trying to build out this infrastructure? So in terms of the overall budget proposals, and I know there were, for example, there were proposals put forth in certain regions for education and mental health that weren't funded, that there wasn't enough money to fund mental health service oversight. So how do you see, essentially, programs for students who need it right now, and then perhaps thinking about how that sort of merges eventually into and over the 3 to 4 years that would take to build the infrastructure, so to create that system. So can you just speak to that portion of what we're going to do to help the more immediate needs, and how that then eventually merges over, let's say, this investment, and over the 3 to 5 year time period as the other investments are now coming online, to bring those together? Has there been thought or planning about that?
Certainly, Dr. Pan, and let me just, before answering that question, just really emphasize and endorse your point about all young people, and not just K through 12. Our focus is 0 to 25. There is a desperate need. We saw it clearly in our community colleges, our other campuses, our other young people, 18 to 25, in work and in education, who had a tremendous burden, and we don't have enough tools for that population to really serve the needs that they have. This focus on that entire age span, and understanding that what works from 0 to 3 is quite different than what works from 20 to 25, and acknowledging how nimble and total these tools really have to become over time. And that's the key piece. It will take some time to develop these thoughtfully in the evidence-based, high-quality, scalable way. But in the meantime, we do have other solutions, other programs that, even if somewhat poorly coordinated because of the nature of different ways behavioral health has been delivered across our state for young people, some counties with a rich menu of services, and in other counties, not so many. And so taking what is already in place and looking where those investments can be made. Senator Pan, you mentioned the importance of the behavioral health investments in schools. We had a January proposal that is still part of the overall budget that looks to create meaningful partnerships between Medicaid managed care programs, county behavioral health, as well as schools, so that they can immediately build the connections, the relationships, the infrastructures to get young people with needs immediately connected. I think what we run into consistently, and this is the hard piece to solve overnight, is that workforce shortage. There will continue to be wait for some of those professional services. So as we turn to investing in additional community-based organizations, really building up their infrastructure through this proposal. And even though some of the components won't be complete until, a year or two down the road, we can start to take parts of these programs and put them into place right away. We've talked about potential for building on some of the existing platforms. We have Cal Hope that exists, was built up for the pandemic, that could be invested in. And then, of course, at the Department of Managed Healthcare, we have the helpline that could be a resource, and we've considered how that can become and evolve into something that could be immediately available to families. I do think, though, that it does take time to scale the comprehensive solutions. And in the meantime, we can make some of these investments. And I do think the way you described it is exactly right, that we'll take some of these investments now and allow them to flourish and braid into the broader plan that is outlined in this proposal.
And then, so for example, let's just this behavioral health services virtual platform, is that platform, well, let's put it this way, is there a model for that platform that currently exists, or are we essentially inventing it? And then the second question is this a platform you envision that would be available more broadly, let's say, not just for, let's say, state or local, services, but potentially be available more broadly as a mental health platform for other mental health providers and systems and so forth, in terms of helping deliver care. So, I mean, could this be a platform actually that then serves all patients, not just for the state programs? So and maybe that's even further into the future, but I was just wondering as to what the vision for this platform is, and is there an existing model that you're basing this platform idea on, or is this that's actually up and running right now, or is this an innovation that we're trying to build on, create here in the state?
Yeah. So it is both, right? So there are two models of a program like this. There is some work in the UK, and the more comprehensive model, and that UK model is really for college age, higher ed age citizens there in the UK. And then Canada has the closest model to this. It's a step-based model that allows the tools to be available to allow people to step up their need and care. I think the issue here in California is that this is broadly and widely going to be available to young people. To your point, is it just focused on public programs or those who have access to public programs? No, it is meant to be available for all young people in California. We know, and I've, again, that personal experience where some individuals, even with the best health coverage, often run into some of the most difficult challenges getting the behavioral health care and services that young people need, even harder sometimes than those within the public health and public behavioral health system. So really making sure that this platform is the gateway, the front door for all young people to be able to access care. So that is something that we hope will build and evolve over time, and will require depth in conversations with partners, not just in government, but also within the broad health plan and health provider community.
And then maybe just a few more comments, and as again said, realize we could spend all afternoon talking about this, but knowing that we don't have that kind of time. Appreciate the investment in the workforce. I would make note that the LAO's comments about ongoing costs is something that I think we need to better define, because let's put it this way. I mean, the reason we have the workforce we have in behavioral health, some of it's pipeline perhaps, and that's where the investment is going here. But I also point out that you can try to get more people into the pipeline. How many people will actually enter, and then what they will do when they come out of the pipeline depends on the labor market, what the working conditions they have. And in fact, I think in a previous hearing, I also asked not only about building the pipeline, but also what are we doing to incentivize, what is the overall workforce that's out there? How many people perhaps actually have the skills and the training, but actually aren't in the field anymore because the working situation that they find themselves in is not one that they were interested in, or that they decided to find some other path. And so that's sort of related a bit to the ongoing cost part. But what is the pay and benefits of the behavioral workforce? Are we going to find ways to improve that so that more people are attracted both to enter, but also people to stay and be retained, and not either move to other states or go find et cetera. So I think as we're talking about the ongoing cost part that the LAO pointed out that is a bit ill-defined, I think we need to think about that, because we can try to get more people in the pipeline, and it'll take years for people to go through, but when they come out, are they going to find the kind of jobs, the kind of work that we want them to do, and are we supporting that kind of work, right? And I think those of us who are in primary care, and Dr. Galley, you and I are both primary care pediatricians, we also know that primary care pediatrics is one of the lowest paid of all the specialties, and therefore, sometimes you have people not, deciding to do other things because they're for the same training they could have other rewards. Although I'd like to think many of us in pediatrics stick to our guns, despite that. But I think it is something we need to think about from a workforce perspective, not simply the pipeline, but also the endpoint. And then I guess the other thing I would also just mention is I really appreciate, again, the leadership of the Surgeon General and issue around ACEs, but we also have other models as well that in terms of, again, moving things quickly for students who are here, for example, mental health first aid, training educators and techniques like that. So it'd be good to have a little bit of a, assessment as to what type of skill sets and how we educate, again, educators and schools or law enforcement, other folks, where some of these other tools, evidence-based tools may, how they compare as well in terms of being able to provide both identification of children and youth who need mental health services. Well, there's some other tools also we should be considering as well in terms of doing trainings for people, so they can get some initial help as we get them to mental health professionals. So again, thank you so much for your proposal.
Okay, and thank you very much. And yes, I don't think anybody in the behavioral health field goes into this field to get wealthy. But at the same time, we come in to help people, and there is nothing more frustrating than trying to help somebody and not having the resources to do that. And that's another thing that burns people out very quickly. Earlier in my career, we had a lot of people in working in group homes, and we just kind of called them burnout factories because you couldn't last that long. And now we've closed that down. But we still have the issue of kids. We still have the issue of way too high caseloads in our child welfare system, and the lack of just as we have all stated, the lack of capacity in our system must grow, and that in itself creates a better work environment. But being able to reimburse people and have them have enough hope that they can actually help somebody to be able and through that make the system work, but that with a nice rate of pay is also incredibly rewarding. So we thank you for the work. We know that there's more to be done. We look forward to partnering with you. I think we all have the same goal in mind, is to really increase capacity in our systems and to make sure every child who needs help gets that help, so that every adult has a much better shot at being able to live to their full potential. And with that, I think we'll move on to the Office of Statewide Health Planning and Director Landsberg.
Thank you, Madam Chair and members. Elizabeth Landsberg, the Director of the Office of Statewide Health Planning and Development. So I will start with issue 1, which is an augmentation of the Song Brown Healthcare Workforce Program. This request is an increase of $50 million one time available over 6 years for additional awards to fund new primary care residency programs through the Song Brown Healthcare Workforce Training Program. The funding and provisional language requested would allow for additional awards to hospitals and clinics to support new primary residency training programs in underserved areas. We estimate this funding could support up to 10 new primary care residency programs annually. Hospitals that are new to graduate medical education can also take advantage of a higher cap on Medicare reimbursement to leverage federal dollars in the expansion of the primary care workforce in California. This is a critical effort to continue to try to meet California's need for more primary care providers. Should I go on to the other items, Madam Chair?
Let's just take, I don't know that the Department of Finance or LAO has anything on this. I think it's a good program we all support. Dr. Pan?
Thank you, and appreciate this investment. As someone who's a former program director, residency program director in a primary care residency program, I do appreciate this investment. I think the one thing I would just keep in mind, and I appreciate you said this is over the period of years, is that training for a primary care physician was family medicine, general internal medicine, general pediatrics is 3 years. And so as a program director, what you don't want to do is have funding that lets you fund someone for the first 2 years and then you don't have it for the third year. Plus also, in order to get accreditation, you need to build that capacity as well. And that takes some effort and work as well. So I certainly appreciate that this is, first of all, it's over, I think, 6 years you said. And so we're really I'm thinking about in terms of residency classes. So that essentially, since it's 3 years, that means maybe that'll get us through 4 residency classes, and then perhaps we should be looking at how we extend this, because otherwise what will happen is positions would then have to go away, not in 6 years, but actually a few years before, because as the residents are going through, you have to be sure you can assure funding throughout the entirety of training, not just a portion of training. So it's very important to keep that in mind as we're thinking about the funding for these residency programs. And I appreciate that. It seems like that thought was put in this proposal. Thank you.
Thank you, Senator Pan. Yes, the focus is on new primary care residency programs, in part because the way to bring in new Medicare dollars to support the programs is with the new residency programs.
Okay, thank you. Let's move on then to issue number 2, geriatric care workforce program.
Yes. So this is a request for a $5 million one-time increase available over 6 years to augment the $3 million one-time general fund proposed at the governor's budget for geriatric workforce programs. The total awards funding requested will utilize existing workforce programs, adding additional career exploration pipeline, scholarship, and loan repayment awards to existing programs to increase the number of geriatric care providers throughout the state. So using current programs will enable OSHPD to leverage existing infrastructure to increase awards to gerontologists and other geriatric care providers more quickly than developing a new program.
Thank you. LAO, anything?
Corey Hashida, LAO. We have no comments to raise on this proposal.
Thank you. Department of Finance?
Madison Sheffield, no comments, thanks.
Okay. We all know this needs to increase our workforce here. Dr. Pan, anything on this one? No. Okay, thank you very much. Okay, let's then move on.
So issue 3 is OSHPD's portion of the California Children and Youth Behavioral Health Initiative, which Secretary Galley gave such a impassioned and effective overview of. So I'll just quickly go through OSHPD's pieces. So OSHPD is requesting a total of $900 million one-time dollars over 3 years. Of this amount, $700 million is one-time coronavirus fiscal recovery funds, and the rest would be general fund. And this proposal would support behavioral health workforce, education, and training through both OSHPD's existing health workforce development programs and the development of new programs. We're focusing on 3 main goals: increasing a behavioral health workforce that is culturally and linguistically proficient and capable of providing age-appropriate services to children, youth, and families, expanding training for existing behavioral health professionals, and targeting professionals in medically underserved areas and populations. So our first piece of this would create a school behavioral health coach and counselor workforce. The Mental Health Services Accountability and Oversight Commission's recent report outlined the need to create schools as centers of wellness. And again, Secretary Galley talked about this. The report emphasized that unmet mental health needs create learning barriers for school-age children. To establish schools as centers of wellness, California needs trained behavioral health counselors and coaches to provide a variety of interventions and assist educators in improving educational outcomes. Behavioral health coaches and counselors are also vital to implementing a community schools model, where schools offer a wide array of supports and services for students and families, from health and mental health to family supports, from food programs and substance abuse prevention to crisis intervention and counseling. So we're looking to have these counselors and coaches help provide children and youth a choice in how, where, and when they receive services, including virtual services that provide that secure privacy and provide anonymity through the portal that was already discussed. During the initial year, OSHPED, in partnership with subject matter experts, including education and behavioral health, would develop a multi-year plan to launch and implement the school behavioral health coach and counselor system. Another big component of OSHPED's piece would be the development of substance use disorder, or a SUD workforce. So California continues to experience a shortage of SUD counselors and clinicians. So recognizing this need, we're looking to develop a SUD workforce that provides age-appropriate treatment, a pipeline of SUD counselors and specialists to reflect the diversity of California, and children, youth, and families to help get them the treatment they need in a manner that is culturally and linguistically proficient. So we're seeking to develop a culturally competent SUD workforce that expands the knowledge of existing licensed behavioral health clinicians to provide age-appropriate SUD treatment, as well as investing substantially to address significant workforce and diversity shortages by providing financial support to individuals entering SUD careers. So in this budget year, we would collaborate with subject matter experts and stakeholders to develop a new SUD workforce framework and then plan focused on youth and families. Another piece of the proposals would expand training capacity for psychiatry and social work. Again, we see research that one of the largest behavioral health workforce needs are in psychiatry, especially child and adolescent psychiatry, public mental health nurse practitioners, and social workers. Our proposal would provide funding to support and grow residency and training programs that develop this needed workforce. We're looking to build on existing programs such as the WET Psychiatric Education Capacity Expansion Program, and add programs that train non-prescribing clinicians and child and adolescent social workers and child welfare workers. We are also looking to build the behavioral health workforce pipeline. The Future Health Workforce Commission report highlighted the need to build a pipeline of healthcare workers. This proposal will build on existing programs such as our mini grants program to support career exploration and sustain and build pipeline programs that provide mentorship and academic, career, and psychosocial supports to prepare students from underrepresented and low-income backgrounds for behavioral health careers. And then we're looking to build earn and learn apprenticeship models to help provide a pathway to a job. Earn and learn models have been shown to be effective in training and placing individuals in needed occupations. These models provide tuition support and on-the-job training at a behavioral health provider organization, while the participants attend post-secondary schools or complete training. The employers provide a position for the graduate, and then there's a period of service obligation. The program would provide financial support to the employer to supervise and mentor the student. OSHPED would leverage this model and work with subject matter experts to develop a plan to build the workforce for these counselors, including for unlicensed but trained professionals. Areas of focus could include community health workers and psychosocial rehabilitation specialists that serve children, youth, and families. Given the significant wealth gap along racial lines, this is an important approach to help diversify California's behavioral health workforce. And then we have a goal around expanding training for existing behavioral health professionals So one is focused on enhancing training to serve justice and system-involved youth. That proposal would develop and implement enhanced training to existing and new staff across a variety of sectors, including child welfare, education, and probation, on effective behavioral health strategies with justice and system-involved youth and preventing such involvement among high-risk, vulnerable youth and their families. To implement these trainings, OSHPD would consult with relevant state departments and organizations as necessary to develop and implement a plan to provide this training. A second proposal would expand behavioral health training for primary care providers through our Train New Trainers Psychiatry Fellowship, Train New Trainers Psychiatry Fellowship Scholarship. So this current program would be expanded to include pediatricians and other providers serving children and young adults. The program provides training to existing primary care staff to directly serve rather than refer for moderate behavioral health conditions. Primary care providers continue to be a primary source for mental health treatment. Providing adequate training on behavioral health issues to these providers is a critical component to the integrated team model of behavioral health. And then there are two last pieces that I want to highlight, focused on targeting professionals in medically underserved areas and populations. One would be to expand the peer personnel training and placement programs. So we've seen the Future Health Workforce Commission report highlight the need for frontline workers to contribute to addressing California's workforce challenges related to supply, diversity, and geographic distribution. Peer providers can help meet the increasing demand for team-based integrated behavioral health, drawing on lived experience. We at OSHPD currently have a successful peer personnel training and placement program that trains and places peer personnel in positions throughout the public mental health system. We're seeking to expand this program by training up to 2,000 peer personnel, building a diverse workforce that supports improved health outcomes and promotes recovery and self-sufficiency. We are also seeking to train up to 1,250 peer personnel to focus on transition age youth. These individuals will fill an important gap in the workforce to work with at-risk youth. And then finally, we're looking to augment our existing loan repayment, scholarship, and stipend programs to support behavioral health disciplines. So those pieces are all outlined in your in the agenda. Happy to answer any of your questions about this, and I'm joined, Stephanie Welch, of course, is still here, as is Karen Reisel, our Workforce Deputy Director. But I really would note that they deserve a lot of credit for putting this proposal together, trying to leverage OSHPD's existing programs and really fill the need and meet this unique moment in time.
Thank you very much. Department of Finance, anything?
Madison Sheffield, Department of Finance. No comment, thanks.
Thank you. Mr. Ashida, I see your hand up.
Thank you, Senator Eggman. Corey Yoshida again with the LAO. I'll be very brief with our comments on this issue. You know, for this component of the Children and Youth Behavioral Health Initiative, you know, similar to like the comments that we raise on our on the overall initiative, like we would really stress the importance of designing an effective evaluation strategy for these investments. You know, some of this funding is going towards existing OSHPD workforce programs, and some of it is going towards establishing new programs. You know, given that the state generally has not sort of had a clear picture of the effectiveness of existing workforce programs within OSHPD, you know, we would extend this, you know, consideration about the evaluation design of this funding towards both the new programs as well as any potential sort of refinements that can be made to OSHPD's existing programs in order to sort of gain a clearer picture of whether there are specific outcome metrics that have been reached as a result of these investments. Those are all our comments at this time, and happy to provide further assistance where needed.
Thank you very much. I guess I would just first note, you know, we just can't keep saying this enough, that once someone is trained, the workforce issues remain huge at job retention, being able to keep people in. And I guess I don't have as many questions about, and again, you know, all of this will need more detail, but of the existing professions as we know them. But I guess I'm interested in knowing your ideas about who are these health coaches and counselors, and who are these earn and learn folks with the apprenticeship model. I guess that makes a little bit more sense to me, because we already have not enough behavioral health folks. Now it sounds like we're creating new positions. And somebody who served on business and professions for a long time, I can tell you scope issues then that becomes a whole battle in itself, who can do what. And then my other issue, also is serving in this for a while, is the issue of, if we're going to create these new positions, are we also going to then do a corresponding investment in our higher education system? Otherwise, we are asking the for-profit college system that is out there and thriving to create all of these and provide the education and send our probably lower wage earners in our behavioral health system into higher rates of debt. So can you talk about who are these coaches and counselors and earn and learns people?
Thank you, Madam Chair. I'm going to see if Deputy Secretary Welch wants to talk about that a little, and then we're happy to add on as needed.
Yeah, absolutely. And so we were looking at models that are obviously in a variety of places, but the core principle behind actually both the coaches as well as the earn and learn model is to have a low barrier to entry into this workforce, and for us to actively recruit from underserved communities that could come into this workforce and really represent the cultural, linguistic, and diversity that we need in our workforce. So a coach is really, we wanted to make sure that it was clear that it wasn't the same as a community health worker. It wasn't the same necessarily as a peer, because the thing that would make them unique would be the specific intensive training that they would get to really engage and support children and youth. So this, to be specific, also as a social worker speaking to you, this is an unlicensed, envisioned as an unlicensed but trained and highly qualified workforce. And kind of similar to an earn and learn model, this model would only work, especially if we're going to recruit from communities that are not currently as represented in our workforce, would be something that provided a stipend, provided enhanced professional mentorship, and support in potential job placements. But again, the thing that would make them unique would be that they had the ability and the opportunity at no cost to themselves to get this intensive training that would make them able to work very effectively with children. I think probably something that you've heard, and I've heard it in previous hearings, is that we just simply, yes, we have a workforce deficit all around. We've been talking about that for 2 decades in this field. But we also really have a deficit in terms of people really having the ability to not only engage, but to really work with children and their families. And so this is something that would really need to be developed, and we envision it being developed with the expertise and partnership of our higher education partners, as well as our partners in K through 12 education. And so we've started those conversations. We recognize that this is something that is a vision that we have that is quote unquote new, and it will require some planning, because we want, again, these systems to utilize these individuals as well as help us produce them. The behavioral health concept of a counselor is really just a generic term. We see this as somebody who could have a variety of different certifications and licensures. Maybe this could represent substance use counselors. It could represent somebody who has their BA but has graduated from a social work program and wants to become a case manager, et cetera. The idea is that these are individuals who would have a stronger skill set, so to speak, or a more robust skill set that, in essence, a coach could do a warm handoff to or a referral to. Another question that we've gotten about this concept of really rapidly being able to produce a workforce that specifically has skill sets to work with youth, young people and families, or children, youth and families, would be that they would have if they were in one of the programs, I'm not going to use the right term, Elizabeth, I apologize, but they would have some sort of a service obligation, so to speak, to work in a variety of different settings. So they potentially may go off and see and apply for a job in an educational setting. They may choose to work in a small CBO. Maybe it was even the CBO where they did their internship. Maybe they choose to work for county behavioral health. I think our concept around this population is to produce, I don't want to say a new generation, but hopefully a large group of people who may not necessarily have had the opportunity or hadn't maybe even considered going into the behavioral health care field, but that it can be a rewarding and also financially, I don't know, I want to say financially rewarding, but still a good job, a good paying job. And it's everything from something that's more entry level to a job that provides many opportunities, including returning to school and getting additional licensure. And so that's really our vision. And we do think that this is something we really want to work with our educational partners on to help not only identify existing students who may be getting ready to graduate and might be interested in being a part of a program where they could get some intensive training and be more workforce ready, to ways in which we can partner with our local community colleges and other training entities to rapidly train individuals effectively to have this unique skill set. So I think that answered most of your questions on that concept.
Yes, yeah, and you and we both know this is. I mean, you're very optimistic, and this is. I mean, this is. I see it, right? I see the optimism, and I see the dream, but I see a lot of landmines in between the implementation. And just a little bit about the substance use. Are you talking about KDAC people then, certification? Or are you talking there also about a range of a career path? I guess is that what we're talking about? And then if we do that, then again this issue of pay, because we don't want to create a whole right people that are vastly underpaid. Somebody with a degree, and then so any thoughts?
I think this potentially might be a question for Karen, with kind of thinking through kind of the process that we're going to embark on in order to really examine how to build out the substance use workforce that we need. Would that be something that Karen could speak to?
Yes, Ms. Frizzell, please.
Yes, good afternoon. Well, I think one of the things that we're looking at, specifically around the SED workforce, is how to build a career ladder. Mm-hmm. And so I think that because we recognize that we want to build a pathway from lower entry-level positions into higher-level positions. So that's one of the key pieces of this proposal is really developing that career ladder.
So we're not quite sure about. So we're still working out a lot of the details of it. But I would concur with your goal of trying to create some kind of workforce ladder through this, and making sure that we partner with our institutions of higher learning, so we have the training easily and available to people. And we know it's a lot of years and education to get an advanced degree, but we also know that we're working with human beings, and so it is very also delicate work. And while we want to expand it to more peer support, we also know that comes with some liabilities as well. So supervision would have to be a huge component of this. So a lot still to be determined, but we thank you. Dr. Pan?
Thank you, Chair Eggman. I have to admit, I still have significant concerns after hearing the answer from the department, and just respectfully, I'm honored to be working with a chair who has a degree in social work, an advanced degree in social work. I myself am not only a physician, but I've done advanced training in behavior and development. And of course, I also ran a training program for pediatricians. I was the program director. And so as an educator, I'm hearing some of your answers, and it's actually making me very concerned. Because I'll tell you, as a program director, so I get people who graduate from medical schools. They've had 4 years of college, 4 years of medical school. They probably did pretty well in college to get to medical school. So they're pretty talented people. And they show up, and we have them go take care of patients. But we don't just send them to take care of patients. We keep a very close eye on them. Because it's hard work, and it's not just difficult. The consequences are significant if they make mistakes or if they're wrong. And so these are people who have already gone through 8 years of training. And by the way, even when they're finished their additional 3 years of in-person experience, they're still not qualified to train as an expert and specialist in behavior and development. That's another 3 years of training. And I also make note that one of your training programs here is actually to take these very same people who've gone through that much training, 4 years of college, 4 years of medical school, 3 years of residency, and say that, oh, by the way, you need even more training to take care of moderate behavioral health conditions. And actually, you know what, that's not necessarily inaccurate, because as someone who's actually done my fellowship training, the thing that I realize is that it's, behavioral health is, it's not simple. It's challenging. And so the question it starts to raise is that, and I get, we're trying to build up a workforce, is that these health coaches and counselors, you talk about intensive training, but they're unlicensed. So that seems to be an oxymoron. How are they intensively trained? I mean, I guess we don't necessarily have to give them a license for intensive training, but how can you say they're intensively trained and it doesn't necessarily have to lead to a license? So what is this intensive training? How many years? How many hours of training is intensive training before we unleash them onto a bunch of students and children in schools, right? And I'll tell you again, as a program director, the thing that always worried me most were the residents who thought they knew more than they really did. And those are the ones I had to keep the closest eye on, right? So sometimes knowing just enough is actually more dangerous because you don't realize the limits of what you know or don't know. So what I'm concerned about is we're rushing to get we're going to create this program that doesn't exist, right? So we're going to invent this behavioral health coach or whatever. And then we're going to do I'm interested in the question as to how much training they're going to have. They're unlicensed, okay, but exactly how much training is intensive? The word intensive, what is the definition of that? And then when they're in these schools, are they unsupervised? Is someone keeping an eye on what they're doing in case they overextend themselves? Is there going to be a master, someone who actually has professional training and who's licensed and accountable
Yes.
in terms of their to monitor how many people are they going to be supervising? How many licensed professionals are going to be watching over them? So that person's going to have 12 of them keep an eye on, or are they going to have 4, or how many people? So I appreciate the general idea. You're trying, okay, how can we try to rush this workforce? But I also want to be very cautious about what we're telling people they're actually getting. And by the way, I do agree that what we should be thinking about is how we build a career ladder. So I'm not saying that you can't have people who are going up a career ladder and trying to get them an opportunity and also be able to utilize what they have learned to be able to help deliver some services. But I want to be very careful about, exactly what kind of expectations we're setting on the people receiving those services and what these people can do, not only the students and their families, but also even the teachers and the other staff in the school about what they can do. Because I know when you're short, you just desperately, by the way, when back in the Great Recession, I had, as someone who takes care of a lot of children who had learning disabilities and behavioral issues, I had parents, because they had their mental health cut when we were cutting state services back in, back in 2008, 2009, asking what I could do therapy for them. And I said, well, I'm a fully trained physician, but I'm not a psychologist. I can't do therapy. I'm not trained to do that. And so will this person know enough to say, no, I can't do that for you. I don't know. I'm not skilled enough. So can you please help me understand what's intensive training mean? Who's supervising? What kind of standards are we putting on these behavioral health coaches and counselors?
So with the coaches, I think when I mean, so when using the term intensive, these potentially are envisioned to be full-time 12 to 16 to 24 week, 40 hours a week training.
24 weeks. That's it.
These are not people who will not be supervised. Their training is simply to get them into a place where they could be supervised for up to 2 years by a licensed professional, kind of like an on-the-job, I don't want to say it on the job, but in social work, we do that. We have to get our 5,000 hours. So again, the idea is to have some classroom, so to speak, intensive training, but then to really work with more professional staff that they could refer clients to. And part of a lot of what that training is exactly what you just mentioned. They're identifying signs and symptoms, and they're recognizing when they should refer the young person to a professional. So it really is getting back to that original concept we talked of at the beginning of the hearing, which is empowering more of an ability to identify and refer, and opening that door so that more people are going to have an ability to have a warm handoff to the care that they need. So if it was portrayed that the coaches themselves would be delivering a variety of different types of care that was clinically based, I apologize for that. That's not necessarily what we envisioned as these coaches.
Okay, so just to clarify then, so I'm just trying to imagine the sequence of events. So you're in school, your child appears to have some behavioral issues, not doing well in school, perhaps acting out somewhat. There's this behavioral health coach in the school. So are they in the classroom watching students? Are teachers then having to refer to them, principals? And then the supervision, is that in-person supervision at the school? So we're going to be sure we have a licensed mental health professional at the school. So can you I'm just trying to get a better, more concrete idea about exactly where these coaches sit and how they how do they get the people in front of them, and of course, then hopefully they're trained to figure out how to make the referral to a licensed professional. But how's that sequence of events supposed to happen?
Okay, and let me, before you try to answer that, Ms. Welch, because I don't know, or Ms. Rizel, I don't know that anybody can really answer that right now. I think you are still in a conceptual phase, as I understand it. And so I think what you should take from this is that there are some concerns. I will also say that I started off before I was licensed, and I worked in a substance abuse program. I worked in a therapeutic long-term substance abuse program. The first time I ever heard the word social worker, it came with an MF in front of it. A paraprofessional was asking me if that was what I was, because he thought I was being too kind. So I know that people come in all kinds of flavors of experience, and sometimes those with direct experience are very helpful. But I also think it's always good to have a real a blend and make sure. Again, the issue of supervision, I think, is imperative. I know in classrooms, if a teacher can have a paraprofessional, that is fantastic. And I know they are often not degreed people, but certified and taken some classes. So I understand the model. I think we all understand that model. But I think there's going to be a lot of questions going forward about supervision and who these folks are and what their training is and all of that. But I think we all understand the need for a career ladder, and we also understand that everybody is not going to be a degreed professional, but that there will be checks and balances and supervision built into the system. Is that what I'm understanding?
Yes, that is our goal, and again, why we really want to have that planning year to work with our partners to design something that is going to have their expertise, obviously, but again, hopefully help us in the long-term capacity to have a group of people who can come in and maybe be a coach for as long as they want, or potentially continue on with their education and their skill set. So I think we're excited about it being a new opportunity to have a different expanded capacity. In particular, again, our hope is that we will be able to recruit people who may not have been interested in going into this field and or really want to give back to their communities in a meaningful way.
Okay.
Thank you very much.
So I guess, and again, appreciate you getting back to me with the answers to some of those thoughts. I realize you're still evolving, but that also means what is the infrastructure for all the supervisors too, right? So, we're going to have these coaches, we have this budget line for coaches, then where the supervisors coming from? Because let's put it this way, we don't have enough school nurses for all the schools. We certainly don't have enough licensed mental health workers in schools as well. So we're going to create these coaches in the schools, and they're going to be supervised, and we need to know who the supervisors are and where we're getting the supervisors. I would just make one other comment as well, and this goes back to, again, this behavioral health training for primary care providers, which I agree with, and that we should encourage primary care staff, including physicians, for moderate behavioral health conditions. But I'll tell you, as someone who actually does that work, who did that work clinically, one of the challenges is, it's not so much, just part of it's the training part, but actually the real challenge was this, is that, and again, this is perhaps a more question for DHCS actually in the long run than you, but since you're doing this part of the workforce piece, is that as a primary care doctor, I didn't get reimbursed for the time it took to do the mental health work. So on one hand, while I would try to do some of the mental health work as someone, again, fellowship trained, behavioral developmental pediatrician, that the clinic directors and the billing managers would go, wait a minute, you're doing all this work that can't be billed for, and you're spending time that is not something we'd normally bill for, and so maybe you should stop doing that and just refer those people instead of doing it yourself. And so I think, again, this goes to the disconnect between someone being trained for something and the systems that support or don't support those type of activities. And so again, I realize this is perhaps outside your department, but again, as we're building these workforce pipelines, we need to be sure that they can go into positions and that the positions themselves support the types of activities we're trying to train them for. Otherwise, you're going to have, we'll get people through pipelines who we find out aren't doing the things we're hoping they would do because their positions don't actually allow them to. Thank you.
Thank you very much. Okay, let's move on to our miscellaneous technical adjustment on the last one here.